Hi, everyone. Welcome to our Unit 2 discussion here in ST 135. This week, we're going to be talking about general supplies used in surgical cases. There's quite a few, so we'll have a lot to talk about. So our objectives for this week are just to demonstrate knowledge of the variety of surgical supplies that we're going to use, sutures, lots of different types of sponges, syringes, dressings, even catheters we'll get into a little bit today. All right, so your assignments for this week, there aren't too many, but your discussion post, you have a small little assignment that's 20 points, a quiz, it's kind of the usual here. Don't forget to submit your first discussion post by Wednesday. So I went through and graded everybody's first discussion post. Make sure you go back and look at any notes that I have made for you in this little comment section box, and then make those adjustments so you don't keep getting points taken off for the exact same thing, because those add up over time. So go back, double check those, and also make sure you're responding to at least one peer by Sunday. So your initial post on Wednesday, go back and respond by Sunday. A lot of you forgot to go back and respond. Okay. All right, so let's first talk about our supplies. Why is it important to not only know what they are, what the names of these supplies are, but how many should come in each pack? That's kind of the second part to this topic today. You have to know exactly how many are in each, because you have to have like a basis, a starting point, right? You have to know what should be there in case something is wrong, right? So we'll talk about how many should come in each of those packs as we go. I have them listed out for you. So that is something you absolutely have to memorize, because when you go into clinicals and you start counting, they expect you to know, not only what the supply is, but how many should be there. And if something is wrong with the amount in the pack, how do you correct it? Okay. Because sometimes manufacturers do mess up. It's kind of, we always like to point it out. Like if you're ever on Facebook and you're in some of those search tech groups, they're like, oh, I found a pack of 4 laps when it should have been 5. We point it out pretty often because it doesn't happen super often. So it's kind of like a unicorn, right? We just find the odd one out, or a double suture pack that should only have one. Sometimes it doesn't happen very often. So um, you have to have that critical thinking to know how to correct things that are not what they should be. That's a big part of our job. Okay, so here's a few of them. All right, so we first start talking with soft supplies. We call these soft items, which kind of makes sense because they are sponges. We do have sharp items, right? So some places will separate their counts by those titles too. Count your softs, count your sharps, or hard items. Okay, so the first one here are laparotomy tapes or laparotomy sponges. They are also sometimes just called laps, lap tapes. Can I get another pack of laps? That's very common. So this is what they look like here. They are always packaged with, this is paper, like a little paper binding to it, so to speak, to keep them together. They should come in packs of 5. That is typical. All right, so laps absorb larger amounts of fluid, and it's kind of hard to see in this picture. You can kind of see it where it's darker here, but laps have a blue strip kind of like this one below it, a little bit thicker, that make it X-ray detectable. So these sponges, because they're X-ray detectable, we can put inside an open body cavity like the abdomen. That way, if for some reason we lose it or we can't find it in our counts, we could bring in a portable X-ray machine and it should show up. So it should, by that strip, show up as X-ray detectable. Okay, so packs of 5. Our next one right below it are Raytex sponges. We call them Raytex. Some places do call them 4x4s. That's kind of an iffy one, because sometimes people also call dressings that look very similar 4x4s, and they are not X-ray detectable. So just go with what your facility says. We just call them Raytex. They absorb smaller amounts of fluid. They are smaller and they're much thinner in size than the laparotomy tapes, but they are also X-ray detectable. They've got that blue strip, but these come in packs of 10 as opposed to 5. Packs of 10. Now, these little paper binding things that kind of keep them together, keep those on until you're ready to count with your circulator, okay? Because if for some reason you take this off, like as soon as you start, setting up your table and count maybe 15 minutes later and you're missing one, did it come that way? Did you start with a pack that was off, or did you lose one in the process of setting up your table? You don't want that. You don't want any question up to when it may have been lost. So it's best to leave this, don't break it until you're absolutely ready to count with your circulator. A little tip there. Okay. Then you have dressing sponges, like I mentioned up here. Sometimes they are called 4x4s, but there's so many types of dressings and dressing sponges. They do not have an X-ray detectable blue strip like this one does. All right, so that means you really should not open any dressing really until the very end of your case, because they're not countable and they cannot be found easily on an X-ray if for some reason you accidentally grab one of these when you meant to grab one of those, Ratex or Laps. So it's best not to even have them on your field until your final skin incision is closed and you're actually ready to put that dressing on, because you can get in a lot of trouble by accidentally losing one of those. These Ratex and even dressing sponges, when they get saturated with blood, they ball up into, it's so tiny. It's like minuscule how easy they ball up like a little tissue. So they do become very difficult to find when they are saturated. All right, some more soft supplies. These top two are countable as well. So this one comes on a little like paper card. They are called tonsil sponges. They're just used to absorb smaller amounts of fluid in the back of the throat during a tonsillectomy. They are X-ray detectable and they come in packs of 5. They have a long string on them. There's a little blue strip in here that is X-ray detectable, but the long string will hang out of the mouth while the surgeon is putting pressure on the back of the throat and then pull it out by the string. Okay, packs of 5. And then this one below it are called cottonoids. Cottonoids can also be referred to as neuropatties. That's what we always call them, neuropatties. But they come in a variety of sizes. There's a ton of sizes, okay? So they are sometimes also referred to by their size. So for example, in this picture here, this particular size is a 1/2 by 1, okay? And it's measured in inches. So it's a 1/2 inch by 1 inch long. So you could use your knuckle if you ever do that. Your knuckle right here should be about 1 inch. Sometimes get my little ruler out. So you could have 1/2 by 1/2. There's even a 1/4 by 1/4, which is even, it's super small. It would be for very delicate cases, smaller things. 1/2 by 1, 1/2 by 3. That is much larger. And I think there are even 3 by 3s, 3 inch by 3 inches. They're really big. So it depends on what you're doing. Somewhere it's going to be near the brain or spinal cord that you're going to be sponging these with. So neuro cases, any neuro case you have, you're probably going to have these. Packs of 10. Okay, they do have a string attached to them. Keep the string attached. That little blue strip is X-ray detectable, like all the others. And keep this card that it comes on, this paper card. So when you're using them and you get one back from the surgeon, take that string and put it in the 1 slot and hang the sponge down for the used side. Like you kind of would, you'll see it with the sharps. You want to keep them in order, keep them neat. So when you go to count them at the end, you can see that they're all there. The string is still attached. It's easily countable. Okay, so they're cottonoids or neuropatties. And our last soft item here is called telfa. It is not necessarily used to sponge or anything during the case, but it's often used for either a dressing or to place your specimens on throughout the case or at the end. So again, not countable. It is not X-ray detectable, so don't put it inside a wound. These can be cut for smaller sizes, smaller specimens, different dressing shapes, whatever the surgeon needs. But you can even get like a little bit wet, put your specimen on it to keep it moist if necessary, and then you can kind of wrap that specimen up and hand it to your circulator to put it in the specimen container, however it needs to be sent. Okay, so that is telfa. All right, so I wanted to show you this video on how to make a sponge stick with a Raytech. So Raytex can be used in a variety of ways. You could have it just as a sponge in certain cases. Now, if you're doing a big open belly case, do not use Raytex just free without anything holding them because they'll get lost. Even though they're X-ray detectable, they ball up, they'll get lost. So in certain cases, if they want to use that Raytech, it needs to be loaded on a sponge stick, a Forester sponge stick. So there's a couple ways to load those, and it might be surgeon preference. Maybe your facility makes you do it a certain way, but there are a couple varieties of ways to actually load a sponge stick. So the point of putting a Raytech in the jaws of a sponge stick that is clamped is for blunt dissection or absorption. So for blunt dissection, you've got this here, they can push this through tissue, certain types of tissue, to separate it. And it's a little less traumatic than using scissors or a knife or something. It just pushes through the tissue kind of gently so they can get through it. Now, sometimes if we're going to be doing like a DNC, a dilation and curettage, in an OBGYN case, they will use the loaded sponge stick for absorption in the cervix, like maybe at the end of the case or something. So two options for use there, but let's see how they load them.
So I'm going to show you 3 different ways to create a sponge stick. Now a sponge stick is a Forester clamp wrapped with the end wrapped with a Raytech so that it can be used for several different reasons. One of the reasons we might do this is for absorbing a little bit of fluid that might be in the wound that we've created, maybe to apply pressure to a bleeder in the wound, or most commonly for some blunt dissection, just so we have a nice soft tip on this so that we can bluntly push some of the tissue out of the way. So we're going to create a sponge stick that will allow the surgeon to do this. Now we start with the Forester sponge stick. Now I have 2 different sizes here, a smaller one and a larger one. I prefer the larger one. And there are 3 different ways to create the sponge stick. 3 different ways to wrap the Raytech around the end so that it stays on there securely and it does what we need it to do for the surgeon. So for the first method, which is the most straightforward method, is probably the fastest method to create a sponge stick, is fairly simple. What we're going to do is we're going to take our Raytech and we're going to fold it into thirds. So we're going to fold it into 1/3 and then a 2nd third. So now we've got it folded into thirds. And then with the blue stripe on the outside, we're going to fold it in half long ways. Then we simply take our sponge stick and clamp it onto the Raytech, just like that. Now notice how I've positioned the sponge in the clamp itself. There's about 1 centimeter of the sponge sticking out above the ends, above the tips of the clamp. That way, when it's used against the tissue, it's not pressing, the metal is not pressing against the tissue itself, but also the sponge itself is not too floppy. Now you want to be careful that you don't load it so that the metal tips are too close to the end of the Raytech like I've done here. Because then if you go to dissect against that tissue, the metal tips themselves are actually touching the tissue. And the whole idea of having the Raytech here is so you have something nice and soft, not something hard like the metal tips. So you want to keep those metal tips away from the end of this Raytech just a little bit. But you also don't want to load it so far back that the Raytech then becomes floppy against the tissue that you're pushing against. So you don't want this Raytech sort of flopping around like this. So a good load is going to be maybe 1 centimeter or so down. It's going to look something like that. That's going to be a good load. It doesn't flop around too much, and it gives you a lot of pressure that you're able to apply against that tissue. Now a second way of creating a sponge stick is going to start out very similar. What we're going to do is again fold our Raytech into thirds like this. Then we're going to turn it over, making sure that the blue stripe is on the outside. We're going to lay that down and take our sponge stick and lay it into and across the middle of this folded Raytech that we have. And we're going to take the edges and fold them up and squeeze them into, very tightly pack it down there and hold it in there with your fingers while you clamp down, wrapping the tips of the Raytech all the way around like this. Now again, the blue stripe is showing. Why do we want the blue stripe showing? Because we want it to be obvious to everybody in the room that this is indeed a Raytech, which is allowed to be used inside the body. It's not a 4x4. So having that blue stripe visible to everybody makes it clear that this is indeed a Raytech and we're allowed to use it. Now, one advantage to this fold is it does wrap all of the metal completely in that Raytex, so there's no metal exposed. And very importantly, we want to check the end to make sure that there's no metal sticking out, because if you loaded it too close to the end, then sometimes that metal could come out, and when you go to press it against the tissue, the metal could actually protrude a little bit, contacting the tissue. We don't want that. We want that metal completely covered by the Raytex, and that's what we have here. Now, the third method of creating a sponge stick is probably my favorite. Now, there's a little bit more origami involved, so it might take just a hair longer to create one of these. And if you're in a rush, maybe you don't want to do that. But once you get a lot of practice at this, it becomes pretty quick, and maybe only takes a second longer. And the advantages to this particular method is that it completely covers the metal ends of the sponge stick, so that you don't have to worry about them coming out. And it looks kind of nice as well. And it's kind of fun to make. Now, here's what I'm going to do. I'm going to take the Raytex, and instead of folding it into thirds, I'm actually going to fold it at a diagonal. And not quite a full diagonal, so this corner tip here is not going to quite touch this corner. It's going to be back just a little bit, so it looks something like this. And then I'm going to take my clamp, place it in the middle just as we did before, fold the sides over, putting them into the clamp, and then folding this top corner over and placing that into the clamp as well. And we're going to stuff all of this into the clamp before we squeeze down, and we're going to make a nice tight ball around the end of this clamp. Now there is no way for these tips of the metal to protrude through because we've wrapped the top as well. So this is kind of a nice sponge stick, and it makes it a nice solid sponge at the end of this that we can go in all different directions as we move that tissue around, or maybe absorb a little bit of moisture or fluid that might have gathered in the wound. Now, as you start making your sponge sticks, you'll probably find that you have a preference as the one that you like to make. But also remember the amount of time that it takes to make these. Again, this one takes maybe a second or two longer than it does to take this one. And when you're in a time crunch, that can be important. But also, it's not necessarily just your preference, but it could also be the doctor's preference. Some surgeons have a preference as to the way they like their sponge sticks folded. So make sure you learn all three ways. That way, if you get one of those surgeons that likes it folded a particular way, you're able to make a nice folded sponge stick for them.
All right, so different ways to load sponge sticks. Like you said, it could be surgeon preference. I did the first one. That's how I was taught, just to do the trifold and clamp it. I've never had a doctor say otherwise, but you might have a different preference somewhere where you are. So our next supplies are syringes. A lot of different types of syringes, and this really isn't even all of them. There can be variations of really both of these at the beginning here. So the Luer lock syringe is probably the most common. This is what you're going to use to inject your local anesthetics most often at the beginning of cases or at the end of cases for post-op pain control, but they are numbered, okay? They are measured in milliliters. Kind of can see it here on the side, ml. If you ever hear someone say a cc, like it's measured in cc's, 1 cc is the equivalent to 1 ml. It's the exact same thing. So old school techs will still write things in cc's even though you're not supposed to, because the C can look like a U, which is another unit of measurement called a unit, which is different. So you're really supposed to write out mLs, just FYI. So you're going to draw it up ideally to 10 because math is easier in tens, right, than anything else. Some of these syringes come to 12. You can have a 20 cc syringe. There's 30, 60. 60 is really big. They're kind of hard to draw up the bigger they are. And the bigger ones wouldn't necessarily be for injecting. Very often they might be for withdrawing fluid. So if you're doing say a laparoscopic case and you have a really big cyst on an ovary or something, and they want to withdraw that fluid out of the cyst and maybe send that fluid to the lab for specimen for cytology, you might need a big syringe for that. Okay. So this is most common. It's got threads here at the top. You can kind of see that that's where your hypodermic needle will go, and you twist it in so it kind of locks it in place, because you don't want your needle to shoot off whenever you go to inject it, especially if you're working near the face and that needle isn't tight. You got to be very careful. It could go into the eyeball, right? So it's different than this next one. Look at the tip here. This is a slip tip syringe. There are no threads here at the end to lock a needle in place. The hypodermic needle just sits on top of it. So sometimes this is more used for things like vascular access. So if they're trying to put in an IV, they still have to have a needle, right? But once the needle is in place, wherever they need it, they can slide this syringe off of that needle, but leave the needle in place. It's a lot easier to do that than having to twist it off while it's inside of a vessel. That wouldn't be very pleasant, would it? So this is more of a vascular thing or for other types of maybe injecting contrast with like a tubing of some sort, not necessarily for injecting local. Okay. So the Loralock is really probably the most common. They even come with some that have like extra little finger holes here off the side. That's called a controlled syringe, where the surgeon can put their fingers in those finger loops and inject. It's a little easier than just these tiny little side pieces. All right, our third one here is a baby bulb syringe. So this is this is what babies get sent home with from, from when they're born up in either NICU or on the floor to suck out all the stuff. They are kind of gross inside. If you're actually using them for um at home, like to clean out your baby's nose or ears or whatever, they're impossible to clean out. They're really meant for a one-time use. They can get gross in there if you have repeated uses, which we do not in surgery. But we can use this, let's say on C-sections, to clean out the baby's airway, the nose and mouth, as soon as they're born. Um, some doctors will use it to irrigate with. That is possible. It's not as common, but depending on the specialty or what you're doing, they might want something like that as opposed to this bigger one. This is smaller than that. So this one holds about, I think, 60 mLs or cc's of fluid. So keep track of all your fluids as you're giving it to the doctor and they're giving it back to you empty. And then your last one here is probably the most common way to irrigate in surgery. This is called the asepto syringe. It's hard to see in the picture, but there are markings on it on the side that look similar to what's on your syringe here. So you can see how much is in there or how much is left, still in mLs. So the entire syringe here, the entire asepto holds 120 mLs. You have 60 in the bulb and 60 here in the tubing. So if they give it back to you and it's all the way probably just to the bulb is full and nothing else, you would write down 60 mLs and refill it. You have to keep track of how much fluids you've used in the case so they can keep track of blood loss. In that suction canister, you can't differentiate between how much blood is in there versus how much irrigation you may have used. So you have to do a little bit of math to figure out how much blood is in there versus what you irrigated with. Okay, our next supply are urinary catheters. So we do have some dealings with catheters, especially if you're going to be an OB/GYN or a cysto room. Very often they're going to be working with catheters, maybe more so than others. Circulators can put in catheters, but and depending on your facility, are often trained to put in Foley catheters as well. And again, it depends on your facility if that's okay with them. It is something that's in your surg tech book that we can be trained to do. So if you've had the proper training, you should be able to do it. Two main types here of urinary catheters. You have one that's called an indwelling versus an intermittent. So indwelling is what stays in place that gets the bag attached to it. That's what this picture is here. Indwelling, it stays in, okay? And it stays in because you're going to inflate a little balloon here at the end of the catheter that is going to rest on the base of the bladder before it exits the urethra, okay? So it could stay in place for days, weeks, depending, right? And then the bag would just get changed periodically. An intermittent is just a one-time use. It's going to look slightly different. There's not going to be a balloon or anything here to inflate a balloon, right? There's no extra attachments there, but you don't attach a bag to it. So you're just going to put it in the urethra. You need to have something to catch the urine as it comes out, okay? So like a small basin, a square pan, something to catch the urine as it comes out because it'll come out automatically, right? You don't want it all over you. So one-time use, not attached to a drainage bag. So look at the parts here of this indwelling catheter. We this often comes in like a whole kit. You have a whole Foley prep kit that comes with some sort of prep solution, whether it's betadine, whatever, um, sterile gloves to help put it in. The catheter itself, it's got a syringe, usually pre-filled with sterile water, not saline, sterile water to inflate the balloon with. A little bit of KY on the end of the Foley catheter, and it usually is already attached to a type of drainage bag. There's usually also a little specimen cup if you need to take a urine sample after you put it in. It should be there as well. So this is your typical setup for just a normal Foley catheter. Okay. You do not inflate the balloon until you have put the entire catheter into the bladder and you see urine coming out. If you don't see any urine coming out, don't inflate the balloon. Okay. It's very possible that the Foley itself is still inside the urethra and not in the bladder. You could damage the urethra doing that. You don't want to do that. Okay. So you inflate the balloon with sterile water because saline can kind of break down sometimes it's latex. You can have latex free, but it should be sterile water. And if it's a 10 or a 5 cc balloon, it's a 10 cc syringe. You need 5 cc's in the tubing and 5 cc's to inflate the balloon. So if you only had 5, the fluid would only get pushed halfway and wouldn't inflate the balloon all the way. So you need a little bit more than what the balloon actually is. Different sizes, we'll talk about some of those. For example, here, a lot of different sizes. Catheters are measured in French sizes, FR French. So I would kind of be familiar with some of these more normal sizes. So for an adult female, usually 12 to 14 is common. Males are slightly bigger and peds are going to be like a 6 to 10. Here are the different types of tips to the catheters. I shouldn't say Foley. That one I showed you at the beginning was a Foley catheter. That's normal. These are some variations to that. This two-way channel, that's a Foley catheter. Okay. Now, these two, the Tiemann and Coudet, there should be like a little accent. Accent aigu, accent grave, I forget, it's French. Took like 2 years of French. These, because they're angled, are good for getting around the strictures in the urethras, but usually the male urethra. If they have an enlarged prostate, sometimes it's a little tricky to get that catheter past that stricture where it's tight. You can sometimes use one of these and it like, I don't know, it works, it's magic. It gets around that stricture. And then you can put it in. So has the bag attached, all that. Now, if you look at this 3-way channel here, these are both Foleys, okay? So this one's called a 2-way channel. This one's a 3-way. A 3-way Foley is often used after, let's say, a TURP, where we're resecting that enlarged prostate through the male urethra. So there isn't a stricture. The prostate's too large. It's right around the urethra. But we will hook up a bag of fluid at the end of the case to irrigate. It'll come out the end here, irrigate the bladder and drain it. Helps get rid of some of the blood clots. It helps with bleeding. So that's what the 3-way is for. Right? So I would definitely rise these. The whistle tip, I don't use that one as often in my neck of the woods, but all right, a little bit about suture. We're not going to go into great detail here today because suture can be like a week's long lesson. Suture is probably one of the harder things for students to learn because this is the tip of the iceberg, okay? You have to know what the sutures are used for, what type of tissue. There's a ton of different names. Suture can be either absorbable, like I have a little chart here, absorbable or non-absorbable. Some suture are what we call braided. You can kind of see a picture here, braided, or we sometimes call that multifilament. Some suture is monofilament, like one single stranded, kind of feels like a fishing line. It's really smooth. It's not braided. So different tissue require different types of suture, whether absorbable or non-absorbable, braided or monofilament. And the absorption rate varies. So if we're doing, let's say we're suturing like a tendon, example, If you've taken anatomy, you know that tendons heal very slowly. Same with cartilage. There's not a lot of vessels or vascular supply. So things with limited vascular supply take longer to heal. So I probably wouldn't want to pick a suture that's going to absorb in 42 days when it's not going to be fully healed. You'll just have a recurring injury there. So, not that you're typically the one that picks the suture for the case. However, the surgeon does expect you to probably have at least some basic knowledge of what you're handing them. Okay. And sometimes they don't even ask you for a specific suture. It's probably on their card, but they may just say suture. You need to look and see what you're working on and be able to pick the appropriate one from what you've got. You know, if you're doing the same case multiple times, like a C-section is pretty routine. Okay. You're going to close like the same layers of tissue pretty much every time. Um, so our doctors always use chromic to close the uterus. So if I look and see we're ready to close the uterus, they don't have to tell me that they would like the chromic. Okay. We just know. So you hand them the chromic for the uterus, right? They're ready to close skin. I know my docs typically, if they don't staple, will probably use monocryl to do a subcuticular stitch. They don't have to ask for those things. So it's important to know the names of them, what they're used for, the types of tissue you're going to see it on. Sometimes they have multiple names. We'll get into that as well. So they may ask for, let's say, a polysorb, but Vicro is another name for that, right? So it is a big thing to learn and understand suture. They're colored packages. You'll learn them by their color. Even though they say the color could change, it hasn't changed in 20 years. Like this chromic is like a silver, or not silver, it's like a gold package. Simple gut is also plain gut. It's like a lighter yellow gold. So you'll learn them by their color. So we'll talk about that more in more depth at another time. All right, blades are also part of our supplies. These are our sharp counts. These are countable. All blades are countable. They are numbered. So these are the most common. There's another one, the 20 blade. I didn't picture here, but the 20 blade is a slightly bigger version of what the 10 looks like here. So here's your handle. There are different types of knife handles to fit the different blades and their uses. This is your most common variation, we'll say. Okay, you have the number 3 handle. You see here that's attached to the number 10 blade. So for your basic skin incisions, if we're making a laparotomy incision down the abdomen, this is probably it. Very common. Now, the number 11, because it's so sharp and pointy, is for what we call stab incisions. I know that sounds kind of gruesome, but if we're making like a small incision for a port or a trocar in the abdomen or in the knee for, an arthroscopy, we can use that and just kind of push it in and pull it back out. That's as big of an incision as you need for those types of trocars. It can also be used to make incisions into vessels. We call that an arteriotomy. So it's really delicate, it's going to go easily down the length of the vessel to cut into a vessel. So 11s are for trocar placement and arteriotomies most often. Now the number 12, this weird looking one, looks like a sickle hook. I have seen it most often used in tonsillectomies. Some of the old school doctors would use this to cut around the tonsil to take it out. It's circular, so it kind of like went around it really easily. I would say this is probably one of the least used of all of these. It's just not as often anymore. These all fit this handle. There are other handles that you might have a more common like approach with, I guess you could say. So there's a number 7 handle that's really long and skinny that we might use an 11 blade on, especially if we're doing vessel stuff. It's very delicate. Same with the 15, you might put it on a 7. You could put the 12 on a 7. They fit those as well. It just depends on what the doctor wants and what you're doing. So the 15 is similar to the 10, I guess you could say. It's just a little more delicate. So sometimes we'll use that for making incisions in plastic surgery cases, like maybe on the face, we're going to take lesions off the face or something a little more delicate than a 10. Okay. So that's all the supplies we have for this week. We'll get, like I said, more into some of the others in more depth in other videos. But if you have any questions, again, please feel free to reach out to me, mludwig@herzing.edu. I do have office hours. It was yesterday by the time of this video, before I do these videos, 3 to 5. And if that doesn't work, just reach out. We can set something up. But you guys are doing a good job so far. Again, make sure you go back and check the notes I may have made for you on your discussion posts. That way you can improve and don't get any more points taken off. All right. Have a good day.